What about people's behaviour? Why is it that people do not take the medicines when they should be? There are some common myths out there, and we're now going to hear about some of those myths and what solutions there are from a behavioural perspective, and perhaps how adherent are we in the room today? So with that, I'd like to re-invite back up Dr. Alison Carr.
Well, thank you very much. And we've heard really excellent presentations about the size and scope of adherence, and then some really exciting technology. And what we'd like to do now is pull it all together and talk about what that means for behaviour. And also I'll show you as we go through where we feel that technology is a really good fit, how it really helps us move forward and manage and reduce non-adherence. So I'd like to start by debunking a few of the myths around non-adherence, and I think these are pretty easy to do. And like most good myths, there's an element of truth in all of them, but there's a lot of misunderstanding around them. So I think a lot of the perceived wisdom that you can see from a lot of the more traditional approaches to managing non-adherence are that, people are non-adherent because they forget, they don't understand, the regimen is too complicated. It only happens in conditions that aren't life-threatening. So people are adherent when, if they don't take their medicines, they're going to die or something dreadful will happen to them. And that it really only happens. Non-adherence really only happens when you have asymptomatic conditions. And I think we can fairly quickly run through those myths and see why they're not the answer, why we need to think differently about non-adherence. So patients don't just forget. A few of them do, and I'll show you some data later showing exactly how many forget and in what kind of circumstances. But really, from the numerous studies that we've done, we've found that really, in essence, where it's the only cause of non-adherence, not forgetting to take your medicines, it only occurs in 7% of patients. So there's clearly a lot more going on because we've seen the figures for how many patients are non-adherent with their medicines. The second myth was that patients just don't understand. So we give them the information, it's just that they need educating. If they have the information, of course they'll understand, and therefore they will behave in a particular way. Well, how many people in the room smoke? How many people exercise 20 minutes 3 times a week? How many of us don't drink excessively? It's not about us knowing and understanding the information. There's something else going on. So the gentleman on the left he isn't actually a patient. It's a representation of a patient who was a young man who had dreadful joint pain, who read up information. He looked up on Google and he self-diagnosed himself with gout. He went to see his GP. The GP said, "You haven't got gout. I think you've got rheumatoid arthritis. I'm referring you to a rheumatologist." The rheumatologist, so it's something about me. The rheumatologist said, actually, you haven't got gout and you haven't got rheumatoid arthritis, you've got ankylosing spondylitis. And it's really, really important, as a young man with ankylosing spondylitis, that you take your anti-inflammatory drugs and that you exercise, you use your exercise regime every day, otherwise your spine will fuse and you'll lose all your mobility. So that young gentleman went home, reappeared 6 months later in the outpatient department at the hospital where I was working at the time with a completely fused spine. He had not believed what the doctor had told him. So it wasn't about understanding. He understood perfectly well the information. He just didn't think it applied to him. And when we were talking to him, he said, if I look, the information that you gave me, the patient information sheet said that if you have ankylosing spondylitis, you have this symptom, that symptom, you've probably presented with this. That wasn't me. I haven't got it. Whereas this leaflet about gout, that's what it feels like for me. So it wasn't really about understanding. Also, if you just look at, there have been some studies looking at rates of non-adherence in doctors, they're just as high as in the general population. So it's clearly not about understanding your medicines or the consequences of not using them effectively. So our third myth was that we're non-adherent when our treatment regimens are too complex, and certainly there's an element of truth in that. You know, if you're trying to fit in 4 doses of an antibiotic in one day, when you've got to take it on an empty stomach and you've got to take it so many hours before food, that's pretty nigh impossible for most people with their daily routines. But we make these assumptions and they're not always founded. So there's some data from a study in multiple sclerosis where the assumption was new treatment that was available in a tablet form replacing an injectable was bound to increase adherence because it was easier to take and people don't like injections. Well, that wasn't entirely the story. We found that actually more patients on tablets missed doses than patients who were injecting themselves. So it's clearly not as straightforward as we think. Our fourth myth was about the seriousness of the condition, and I know Amanda gave the example of major organ transplantation, and these data about transplantation as well. Just up to 50% of late acute rejections are because of non-adherence. How can that be possible? So it's not just about your awareness of the seriousness of the condition. There's something else going on. It's not rational. It's not explainable in rational terms. And also, non-adherence with treatment for asymptomatic conditions is a real problem. It's really difficult to manage it and address it, but there's non-adherence with treatment for pain as well. It's just as much of a problem. It's just maybe the way that we need to deal with it is different. So I think what we're trying to say with those myths is that it's clearly, non-adherence is clearly a very complex thing. It's not rational, it's not easy to explain. There's something else going on, and for us, that something else is really about understanding human behaviour. How can we understand what drives that? What's making people behave in the way that they are? And without understanding it, we can't even begin to really effectively change it. So we talked a bit about, right at the beginning, about the myth about forgetting and people making decisions. And some of the patient examples were about people making very reasoned, logical decisions to use their medicines in a particular way. Well, we've collated all the information from various studies and looked at the different types of adherence or non-adherence. And we found that just being unintentionally non-adherent across all those studies, so just forgetting to take your tablets or just being unable to access your medicine, either because of a cognitive deficit or because your dexterity doesn't enable you to open the package, only happens in about 10% of non-adherence. That the rest of it is really down to people looking at their medicines, looking at their lives, looking at it in the context of what their beliefs, expectations, hopes, fears are, what their cultural environment is, what their friends and family tell them, and making very logical, very reasoned decisions to use their medicines in particular ways. And they're the people that's the thing that we need to influence if we really want to make a difference in non-adherence. And it's also the thing that's really difficult to do because obviously it's going to be very individual. It's going to differ depending upon our cultural background, where we live, what's important to us. So it represents a real challenge. Just to give you an example of unintentional non-adherence, we did a study in rheumatoid arthritis where we found that the inability to actually access your medicine, so not just from the child-proof locks where you have to push down and twist, very difficult for someone with hand impairment because of rheumatoid arthritis, but even getting medicines out of a blister pack. Some of the blisters, especially for the cytotoxic medicines, are so thick to be safe that they physically they don't have the strength in their thumbs to push them through. So unless there's someone who can get the medicine out for them or they can decant it, they can't actually be adherent to their medicines, which of course causes potential issues with safety. So we found examples of patients who were emptying their methotrexate into egg cups that they were leaving by the side of the bed or on the side in the kitchen, putting things in bottles where there was a label for another medication on it, so that when a carer or someone else came in, they picked up the medication, they dispensed it incorrectly. Even a couple of deaths from patients who were admitted to hospital who'd done exactly this, had decanted their medication into a different bottle with a different label on it, and the nursing staff had administered it thinking it was what it said on the label, and it wasn't. So clearly unintentional non-adherence is not just about forgetting and can have very serious consequences. But the intentional non-adherence is the thing that I think is really challenging and also very interesting. So those stories that we talked about the different reasons people weren't seeing the doctor, weren't taking their medication. are all they're all individual examples, but they show that we're influenced by really a whole host of factors. And that big circle in the middle represents the kind of framework that can be very helpful that we use when we're trying to understand the behaviours around adherence. So we're looking internally, the bit in the middle, the red circle, about the sort of thinking that goes on in our brains, the sort of things that influence the decisions that we make. How do we think things through? And we talk there about automatic thinking and reflective thinking, and we'll go through those in a bit more detail shortly. But then also, even if your thinking's correct and your intention's correct, your ability to engage in that behaviour may not be there. You may be inhibited because you can't get to the pharmacist to pick up your prescription, or because you have a cognitive deficit, which means you can't remember to take your medicine, or you don't know what it is you're doing, or you don't understand. So it's looking within, and then at the layers as you come out. So the context that someone sits in, their cultural background and environment, the healthcare environment in which they live, the medicines they're able to get access to. So all these factors need to be looked at in terms of really beginning to understand what drives that adherence behaviour. So we're really looking at, as an epidemiologist, I'm looking all the time in epidemiology at what are the risk factors for disease. I want to understand everything that might be a risk factor for that disease. We're doing the same with behaviour around non-adherence. We're looking for what are all the things that could influence that decision to use your medication in that particular way, and have we captured them all so that we can make sense of it. So the sorts of things that are currently used to try and promote adherence are a range. There are complex interventions that include lots of different things like information and cognitive behavioural therapy and different reminder tools and all sorts of things, a whole host of things. But actually, I think that this is from a systematic review that looked at the evidence across all the studies that had tried to properly assess whether adherence interventions work. And you can see from this that of all the randomized controlled trials that are being conducted looking at which adherence interventions work, very few of them were of high enough quality to be included in that systematic review in the first place. And of those, only one of them improved clinical outcomes. 3 improved adherence. 5 of them improved adherence and a bit of the outcome. 8 of them achieved showed no effect, but none of them achieved long-term change. So even if there was an improvement in adherence, it wasn't sustained beyond the length of that intervention. So whatever was happening with behaviour, it wasn't helping people to develop that habit of medicine taking or use that would then carry on and mean that for a long-term condition, their medication, they were using it effectively. I guess that the thing that's really started to change the game is the use of technology, not only in our ability to, for the first time ever, properly measure adherence, but also in the use of that technology to try and promote adherence. So trying to use technology to get to people, to give them the information, to help them understand, to remind them, to change their behaviour in other ways. And you'll have seen over the last very short period of time a huge explosion in the numbers of technological interventions or solutions to try and promote adherence. So, for example, just for diabetes, there are 22 online games to help people manage their diabetes better. 1 in 5, this is American data for the wearable technology, but 1 in 5 Americans wear some kind of technology that helps them to monitor what they're doing. And there are 1,500, at today's count, 1,500 health apps purely aimed at increasing adherence. What are you going to choose? What are you going to do? And I think that the really telling thing about them is that it's all out there, the technology's available, it's being developed, but so far the use has been very short-lived. So 25% of those downloaded apps are only used once. Within 6 months of apps that are being used, that have been downloaded and are being used, people have stopped using them. So they're not adherent to their adherence interventions. So you get into this kind of circular argument. So clearly there needs to be more. And I guess that what we're saying is, that's great, we need to use all of this, we need to use the technology and all the solutions, but first of all, the use of them needs to be driven by an understanding of what that behaviour is about. And only if we understand that can we then make the technology match what those behavioural triggers are. So we've just listed here quickly, what are the barriers to improving adherence? Well, the first barrier that where Proteus has a real solution is that we have not been able to measure adherence up until now. We've had questionnaires that have said, that have been quite judgmental, where they've asked patients if they are taking their medicines as the doctor prescribed. Well, there's a judgment in that question already, rather than asking people how they're using their medication. So lots of the ways that we've tried to measure adherence in the past, by asking patients, by counting how many pills they've used, even the little chips that we used to have, that we still have, in the caps of bottles or in inhalers, they tell you how many times the bottle's been opened. They tell you how many times someone's squirted their inhaler. They don't tell you how many times how the patient has actually ingested that medicine, whether it was at the right time, what the dose was. And that's where Proteus has something that is really important to offer our understanding of adherence, because for the first time we can actually identify who is adherent, who isn't adherent, and what the pattern of adherence is. And that then helps us, when we can identify who's non-adherent, to then try and understand what's driving that and therefore know what to do about it. So I think that's really what we're saying, is this technology really promises greater understanding of the whole issue of non-adherence. So looking at what we were trying to get to today was, how can we change non-adherence? What can we do to promote adherence? And what we would say is, taking all of that evidence into account, is that interventions that succeed are based on really being able to identify and measure adherence, so using the technology effectively, building a real understanding of the behaviour, so why people are non-adherent, why they're using their medication in the way that they are, and then segmenting those patients, understanding that not everyone's not using their medication for the same reason, that there will be different types of patients who make particular types of decisions about their medicines. And so we can start to target the adherence interventions depending upon what's driving that behaviour. And then on the back of that, developing behavioural strategies that will draw on technology and information in order to change behaviour. So it's really about the understanding why. And I guess that this is where we talk about, really, how do we all make decisions? So how are we going to try and make sense of the decisions people make around using their medicines? So we make every day thousands of decisions. If you just think about the number of decisions you made in order to get here this afternoon, you probably weren't aware of how many, even half of the number of decisions you took. So there were decisions about, how you're going to get here. You probably spent some time thinking about that. So that was a kind of conscious decision. You may have thought about what you're going to have for lunch when you came in. Did you think about what you were going to wear? Some of us will, some of us won't have been that interested in it. When you came into the room, how long did you think about deciding where you were going to sit, or did you just come in and sit down? But you made a decision about where you were sitting. So there are different levels of consciousness about the decisions we make every day, and we can't possibly make every decision in a very thought-through, reasoned way. And that really then means that in order to change adherence, we need to understand that process, because it can offer us huge advantages. If we understand why or how people make their decisions, that can offer us a way into changing what those decisions are. So we're talking here about the difference in those decisions, those automatic, quick decisions that we make that we're not even aware of. So the where you sat when you came into the room. If you drive a car, I don't know if you remember that process of learning to drive, where when you were learning, you had to remember, you had to steer, and one foot was for the clutch and one was for the accelerator, and you had to pay a lot of attention to the task. Now I bet you get in the car, you just turn on the ignition and off you go. You don't even think about what you're doing. You can talk while you're driving, you can look at where you're going, you can listen to music. You're not paying attention to it because it's now gone into that automatic side of your brain where it's just happening because it's familiar. You're not needing to pay attention to it. Whereas other decisions like which mortgage you might take out or whether to extend the warranty on your washing machine, for example, you might spend some time thinking that through, and that requires attention and effort. So we make far fewer decisions using that part of our brain than we do using the automatic part of our brain. And that's relevant because we're all governed by, in order to change that non-adherence behaviour, we have to understand what's going on automatically at that subconscious level, because we can tap into some of that. We can utilise some of that knowledge in order to help drive that behaviour change. So this is a mnemonic that was developed that's used by the Cabinet Office to help within their behavioural unit to help understand some of the decision making that drives all our behaviours, and it basically it captures some of the different biases, the things that we're all more or less influenced by. So who gives us the information, where that comes from, is it a trusted source? How are we going to be rewarded for our behaviour? We're driven by being rewarded, but we're more driven by somebody taking something away from us that we already had. So all these kinds of biases, we go with the flow, we do things that, if it's not too difficult, if things are too difficult, we just go back to what we already know. They're all things that you'd recognise, and they're things that within the consumer sector, as in consumer goods, people are utilising these all the time. You walk into a supermarket, you get the smell of fresh bread. That's no accident. What they're tapping into is priming. So you smell the bread, you think, oh yes, even if you don't think, you end up by the bakery counter. Because they're very cleverly utilising all these cues and triggers the whole time to influence our behaviour. And we can do the same with adherence. If we understand what they are, we can utilise some of these in trying to drive and change adherence. So here's an example of a case study just to demonstrate how powerful these can be. This is a study that was done trying to reduce the do not attend rate at outpatient appointments, which is a huge problem. It costs the NHS a huge amount of money in non-attendance. And this study was built entirely on those automatic underlying cognitive biases that we're subject to. So what they did was they introduced a code, a sort of 4-digit code, which you had to give in order to make your appointment. And the idea was that if you kind of had ownership of that code, you would associate it with your appointment, you would be more likely to keep it. Well, that didn't work. So the non-attendance rate went up. So that wasn't a very good idea. So then they said, okay, we're going to get people to make a verbal commitment. So we will ring you up. I don't know if anyone's had an appointment at hospital recently and had a phone call before your appointment to say, remember that your appointment with Dr. So-and-so is on this day. Are you going to attend? Oh, yes, I am. That's your verbal commitment. So we're all driven to, we at least like to try and keep our promises, even if we don't. So subconsciously, that's what we're doing. So when you do that to patients, you ring everyone up. The DNA rate drops by 3.5%. Well, that's okay, but it's not huge. It's not startling. So then what they did was they said, okay, we'll do that. That's fine. That's a verbal commitment. A written commitment is much stronger as something that drives your behaviour. So we'll get people, when they come out of their appointment, when they're making their next appointment at the outpatient clinic, they have to write it themselves on the card. We're not going to do it for them. They will write it with a witness who's the receptionist or whoever's making the appointment with them. So although they're not signing something saying, I promise to turn up for my appointment, the effect is very similar. And when you do that, you see an 18% reduction in non-attendance rates. When you add to that, so you use that written commitment and you add to that a message that's around what other people do, you get a really significant reduction of nearly 32% in non-attendance rates. So that message is that most people, I think it's something they frame it like 70% of people who don't attend their appointments remember to phone us and cancel beforehand. So in the past, people have used messages like, if you don't use your appointment, it's wasting an appointment that someone else could use, appealing to our better nature. That doesn't work. We obviously don't have better natures that are very strong. But giving that message about what everyone else is doing, very effective, even at that subconscious level. We're members of a herd. We like to kind of belong to that herd. So subconsciously, we're doing what everyone else is doing. So they said, okay, this isn't a randomized control trial. We've just introduced these measures. This might just be an aberrant, result. So what we'll do is we're going to stop doing all of that. And for a period of 6 months, we're going to see what happens. And the non-attendance rates go back up. So they reintroduce the written commitment and that message and the non-attendance rates drop again. They drop by 30% again. So quite compelling evidence that very simple interventions aimed at what those underlying automatic thought processes and decisions are can have a significant impact on our behaviour. The other thing, though, is that we mustn't forget is that that automatic thought happens, but it happens also within the context of who we are as people. So what our own beliefs, expectations, cultural norms, everything else is. So that's more like the environment, what we call the mind space plus element. And some of those factors that are really important in adherence are this concept of self-efficacy. So that's one of those horrible terms. It's really difficult to kind of get your head around or communicate, but it's not just self-confidence, it's really the belief that you can successfully engage in a behaviour. So your belief that you can use your medication effectively, even if you don't say it like that to yourself, it's your belief that your self-belief that it's something that you can do is really important. And necessity, that balance between necessity and concern is also really important. And these two things have been shown repeatedly in studies to be absolutely key factors in influencing adherence or non-adherence. So when we don't have a very strong sense of necessity for taking that medication, but we're worried about the side effects, we're probably not going to use it. Where we have a really compelling sense of necessity to use the medicine, that can overcome our concern about the side effects. So it's just that balance. So for us, it's that really understanding what's driving adherence means understanding all of that. So it's understanding what those automatic drivers are and understanding the context in which that happens. So those other aspects around the person, how they make sense of their symptoms and the treatment, what it means to them, what their expectations are, have the expectations been met. And so when we design interventions, our adherence interventions, that's what we use. And so this is an example of an adherence intervention that we designed based on that understanding. So the problem was, as with most medicines, a high drop-off in non-adherence quite early on in taking medicine for a long-term condition. And really the aim was to get people through that early phase and get them to learn that adherent behaviour so that it became more of a habit, and that would hopefully then drive or sustain that adherent behaviour over a longer period of time. And so the research that we did to really understand what was driving that non-adherence led us to a series of little interventions that, when all added together, really had an impact on adherence. And I guess that's what we're talking about, is if you think about the number of different influences there may be on adherence, how could it be that one thing could be the answer? It's really getting little gains, little changes in lots of things that added together give you that impact, that change in behaviour. And also understanding that non-adherence isn't just about the patient. So I think that's the other thing that's quite often forgotten with the big adherence interventions, is they're delivered directly to the patient, not through the clinical team, which means that when the patient then interacts with their own clinical team, some of the messages they've had from those big those big adherence interventions are contradicted, undermined, by their encounter with the clinical team. So it's really, really important that the message is consistent throughout the patient's interaction with anyone that they need to interact with. So that's why the interventions need to encompass all of that. So this intervention included an app. Yes, it did include an app, but not for the sake of an app, but because the app was the best way to deliver the behavioural change interventions that we had designed. So it was a means of delivery, not an end in itself. And that there was training and support for the healthcare professionals involved in the care of those patients as well, so that they understood the behavioural principles and they could support them in every interaction with their patients. So again, we're not talking about big, lengthy, complex interventions. We're talking about things that can be delivered within the context of a normal clinical consultation, which means they're much more likely to be used. Oh, and the outcome, sorry, I missed. And the outcome was an increase in adherence. So with an evaluation of this, 100% adherence in 83% of patients. So that's quite a remarkable impact on adherence. And that the intervention was valued by the clinical team as well. So that's I've shown you the kind of the idea about the automatic thinking and the more reflective thinking, and we asked you some questions before you came today, and I know a number of you clicked on the link and answered those questions, and thank you for doing that because it helps us to illustrate some of the points. And I'll just go through some. I won't go through all of them because we haven't got enough time, but I'll just go through some of them. So remember these questions for those of you who clicked on it. We had a scenario about an outbreak of a rare strain of influenza that was going to have a pretty dramatic impact. And we gave you some options for different vaccination programs or immunization programs, and you had to make the choice about which one you thought that the health service should adopt. And we had them in two pairs. So in the first pair that you had to choose between, we were going to definitely save 200 patients, or you could have a program where you had a 1/3 probability of saving more people, but you had a risk that some people might die. And in the second pair, we had a definite outcome of 400 people dying, but you could gamble that against the probability that nobody would die, and a 2/3 probability that a lot of people would die. So it's exactly, I don't know if you spotted that when you were answering the questions, any of you, but it's exactly the same data, it's exactly the same information, it's just framed in a slightly different way. So we should really get the same answer to those pairs of scenarios, but we don't, surprisingly. So those two scenarios where program A was we were definitely saving lives, even though it wasn't very many, it was 200. We're not prepared to gamble that. We have a certain positive outcome. We like that. We're not prepared to gamble it for the chance to save more lives. No, we're not risk takers. However, for program C and program D, where the definite outcome is death, which is something we don't want, we're quite happy, some of us, to gamble that away against the chance of a better outcome. So a really simple example of the fact that we're all, most of us in this room have a science background or something, we think that we're quite rational, we can think through problems, but we are all influenced by those automatic biases, those cognitive biases that happen at an automatic level. We're not aware of them, that mean that we saw that information differently and we behave differently. So just a little illustration of it. One of the other tasks that we gave you was to, with no time at all, it was deliberate that you didn't have enough time to actually work out the answer, you were supposed to give an estimate, was to work out what the product of those numbers were. So the first one started with 8 and worked down, and the second started with 1 and worked up. And what we found, surprisingly, was that the average estimate, where you start with a high number, your average estimate of the answer is much higher than when you start with a low number. Exactly the same sum, but it's just turned around the other way. And again, showing another of the biases that we're subject to, which is called an anchor bias. So if you present information in a particular way, it influences how big or small that we think things are, how important or unimportant we think things are. So just two illustrations of how even us, all of us, are influenced by at that automatic level where we're not aware of it. So think how powerful it could be if we could tap into some of these unconscious, these cognitive biases in order to help promote non-adherence. So just finally, to put all of that in context, when we're talking about Mrs. Jones and trying to improve her adherence, what we need to do is not just give her information, not just assume that she'll understand, but really understand for her where she's coming from, who is she, what's important to her, how does she make sense of her condition, what's the context that she lives in, can she access her medication, how effective does it be, what is she afraid of. So it's really looking at the whole thing in context. And that understanding of where she's coming from is also really important. So how a patient makes sense of their illness and treatment, their explanatory model for it, and how that differs from how the doctors make sense of the treatment and the condition is absolutely key in having effective adherence-promoting communications between doctors and patients. So within the solutions, it's looking at that really effective communication And I can show you how effective it is. If you base that communication on patients' explanatory models and you build stories about disease and treatment based on their explanatory models, you can influence their outcomes. So these are data from a study using explanatory models with antihypertensives. And you can see that in the intervention group, so this is the group, it's this line here, which looks like it's dotted, but it's just the way it's appeared on the screen. In the intervention group, who had those special narratives, those special stories given to them, their blood pressure reduced over time, where the control group that just had the standard information, their blood pressure didn't change. So kind of tangible, randomized controlled trial evidence for tapping into something behavioural in order to change patients' outcomes through increasing adherence. And so my final slide really is that summary. I guess that the one thing that we wanted you to go away today with feeling was everyone knows that non-adherence is really important. What we wanted to communicate was that it's not easy, that it's a complex behaviour. So solving it is not easy. It requires a bit more thought, a bit more effort. And really it requires looking at and understanding that behaviour. And that the technology, the ability to actually measure adherence offers us huge advantages in being able to do that. So thank you very much for your time.
Thank you so much, Alison. I think that was incredible. What mind-blowing statistics, 10% unintentionally non-adherent. I wonder how many people in the room knew that before that presentation. Absolutely fascinating. And if I'm looking a bit smug, it's because I know that I gave the right answers. I was consistent. So I don't know if I swayed if you took me out the equation, it would have got even more. Anyway, enough smugness from me.